A very good evening and a warm welcome to all of viewers. I'm Dr. Shatil from the Clinical Engagement team here at Plexus. It is my pleasure to introduce our distinguished speaker, Dr. Ramen Goel. Dr. Goel is the Director of Bariatric Surgery at Wockhardt Hospital, Hinduja Healthcare and Zen Hospital in Mumbai. He is a reputed bariatric surgeon with over 28 years of experience in the medical field and is recognized as the first surgeon of excellence in bariatric and metabolic surgery in Asia by the Surgical Review Corporation, USA. Dr. Goel is an expert in bariatric, metabolic, obesity, and laparoscopy surgeries. Notably, he was the first surgeon in India to perform the gastric band and banded gastric bypass surgery. His contribution to the field extends beyond his surgical expertise. He has published numerous research articles in peer reviewed journals, advancing our understanding of these complex procedures. We are privileged to have Dr. Goel with us today to share his insights and experience on the topic of surgery result in non-obese diabetes patients. We welcome you, Dr. Goel. Please go ahead with your presentation.
Good evening, Dr. Shetil. Thank you so much, Dr. Plexus, for inviting me again. And I've been on Doc Plexus for last 4 to 5 years since I was president of IGS, and we have done a lot of webinars with you. For today's topic, I'm going to talk about the results of diabetes surgery. So friends, about 1.5 years back, international guidelines changed, and they said that we can do a surgery for uncontrolled diabetes even if the person is not obese. Mind you, I'm not talking of morbid obesity. I'm saying even if the person is just overweight and has uncontrolled diabetes, we can perform a surgery. Now, this is a major change from our understanding of diabetes or your understanding of diabetes. First thing that we need to realize is that diabetes treatment is just a century old. I mean, if diabetes is there with the humankind for last 6,000 years, insulin got discovered in 1921 or 22, almost 100 years back. And most of the oral hypoglycemics came somewhere in 60s to 80s and 90s, and they're still coming newer ones. So medical management of diabetes started, as we know, about 100 years back. I'm not talking for Ayurvedic and other pathies, which may be there for longer period. And 100 years down the line, now we are in a position that we are able to offer surgery in patients who are not able to control it with lifestyle changes or with medical management. We started it very early. Probably we were the first center in the country which has started doing surgeries for diabetes in non-obese patients in December of 2022. And now it's about 1.5 years. I think it's a good time to look back at the results, how this is working, and in which patients it is working. So I'll start my brief presentation, and I'll be very happy to answer questions now, or you can reach out to us through Doc Plexus or directly, because I believe every family has got 1 or 2 diabetic patients. And a lot of doctors themselves are suffering from diabetes. And as we keep talking, more doctors are getting surgery done for diabetes than they ever got it done for obesity. So I think it's time to look back and see whether we can offer a treatment to a new kind of treatment to our patients. I'll just start my slide presentation, brief one, and then we can go from there. So this is our Center for Metabolic Surgery, which is in Mumbai, and we do both bariatric and diabetes surgery in this center. I'm going to talk to you about this old disease, which has a new avatar or new treatment for it, because whatever treatments are available, they are of great help, but still a very good number of patients remain uncontrolled. And for them now, there is an option available. As Dr. Shithil introduced me, I'm at Wockhardt Hospital. I am also the founder editor of Journal of Bariatric Surgery. I'm president of Diabetes Surgery Foundation, and some more academic commitments. So when diabetes surgery started, there were a lot of concerns. People could not believe that something like this is even possible. Is it legally allowed? Can we do it in thin diabetics? Will it be effective? Will the results be sustained long term? What about diabetes medicines? Will they go away? Will they come back? Will the patient continue to need them? And can diabetes complications be really reduced? And is surgery safe? And then obviously the mother of all questions, what will be the cost of the surgery? I'm going to focus mostly on results today, but I'll briefly deal with these issues just to complete this presentation. I'll play a brief video of one of the patients who underwent this surgery.
हेलो, मेरा नाम प्रीति शार्दुल है और मैं 63 इयर्स क्रॉस कर चुकी हूँ अभी। तो डायबिटीज की तकलीफ से बहुत परेशान थी। 3 बार इंसुलिन लेना पड़ता था, 35 यूनिट्स हर टाइम। तो परेशान हो गई थी। किसी ने डॉक्टर गोयल के बारे में बोला तो सोचा कि ये भी ट्राई कर लो। अभी ऑपरेशन के बाद तो मेरा एकदम लाइफ ही चेंज हो गया है। अभी पहले भी मेरा वजन 93.4 था बिफोर सर्जरी और अभी है 70 बीच में रहता है, फ्लक्चुएटिंग। और बस मैं यूरोप ट्रिप पूरा घूम के आई हूँ और मुझे कुछ भी तकलीफ नहीं हुई। 200 सीढ़ियाँ चढ़ सकती थी, उतर सकती थी, प्रॉब्लम नहीं हुआ। और गोली इंसुलिन तो पूरा ही बंद हो गया और गोली अभी खाली एक गोली है ग्लाइकोमेट की, बाकी कुछ भी नहीं है। और जो अपने के विटामिन वगैरह लेना पड़ते हैं वो ही, बाकी कुछ नहीं है। तो थैंक्स टू डॉक्टर गोयल।
So this is summarizes the kind of impact it has on a person if he or she is suffering from diabetes. This is probably the only modality of treatment of diabetes where insulin resistance is targeted. Since I'm talking to you, physicians and surgeons, in type 2 diabetes, the primary pathology is insulin resistance, while in type 1 diabetes, the primary pathology is insulin deficiency because of antibodies against beta cells. Now, when there is insulin resistance for a prolonged period, then obviously that leads to insulin deficiency. Now, except this kind of surgery, the only medicine which has been effective for on insulin resistance is metformin to a very limited extent. All other medicines targeted blood sugar control. And that is where the challenge is, that we are not targeting the primary pathology of the disease. With surgery, how does this surgery work? These surgeries, I've just made a simple pictorial thing. This is the stomach, this is the duodenum and jejunum. And in terminal part of bowel, that's in ileum, there are GLP-1 receptors from where GLP-1 is secreted. Now, in diabetic patients, GLP-1 is secreted a little late or a little slower, and that's why their sugar levels go up. When we do a surgery, let's say like a gastric bypass, this GLP-1 secreting part of the intestine comes right here, and as soon as the food comes in contact with these, they immediately have blood sugar control because their insulin resistance goes down. Now, GLP-1 improves insulin sensitivity. Thus, there is a restoration of acute insulin response that we all know. It also increases insulin secretion, and it is also believed that it increases number of beta cells in pancreas. Now, this is to summarize all the 3 arms of type 2 diabetes, and it targets all. It also leads to enhanced biliary circulation and calorie restriction, which is fine, but this is primarily the hormonal mechanism. Now, the biliary circulation is unique because bile acids regulate glucose metabolism through these receptors. And one of these receptors regulates insulin secretion from islet cells. It itself leads to increased GLP-1 secretion in islet cells. And it also helps in increased energy expenditure of the body. So after a metabolic surgery or bariatric surgery, there is an enhanced enterobiliary circulation, and that leads to better glycemic control. Now, contrary to perception, most of the people start believing that, okay, as you will lose weight, your sugars will come down. I can lose weight with diet and my sugars will come down. But most of them are weight loss independent mechanisms. And I have put out all these mechanisms here, which are mainly hormonal. And obviously, there are other indirect mechanisms like decreased insulin glucose production. So all these leads to glycemic control independent of weight loss. And this is what physicians, surgeons, and all medical fraternity must understand. Because patient must be told the real mechanism, how this surgery works. And that's why most of the patients are able to stop their insulin within 1 week of surgery, even before the patient has lost, let's say, 1 or 2 kgs of weight. The insulin stops. Sorry, even if they have been taking insulin for, let's say, for last 10 to 15 years or 20 years. So insulin if the pancreas are producing even a small amount of insulin, that becomes effective and patient will not need injectable insulin. Now, since this surgery is the same as a bariatric surgery, people believe that this should be offered in only those patients who are very heavy. But please realize there are publications which says that BMI has no role in predicting success of surgery on diabetes or on other cardiovascular outcomes. There are other measures like fasting plasma insulin, which predicts cardiovascular events after surgery. So this conception, because this surgery primarily started with bariatric surgery, people have started believing that this surgery is only for weight loss, but it has been seen over last 60 years that it has a more rapid and more pronounced effect on diabetes than on weight loss. Weight loss happens over 1 to 1.5 years, but diabetes improvement of control happens within weeks to months. I'll show you the results and then you will realize. This is, friends, not a new concept. In 1955, a surgeon who was doing a surgery for a peptic ulcer published this, that I did a subtotal gastrectomy and the diabetes disappeared. Now, it remained unexplored for almost 70 years before surgical community and medical community realized that surgery is indeed a good treatment for diabetes mellitus. Now, what happens when we offer this surgery for diabetes? Now, there are multiple publications, and I'm going to show you our own publications also, which shows, this publication shows that 80% of diabetic patients will have normal blood sugar even at 1 to 2 years after surgery. That means it happens early. And 1 in 3 patients will not need medicines even after 10 years. So please, this is important. The treatment is of blood sugar treatment is not for medicines. We are not trying to replace medicines. We are simply saying patients who are not able to control medicines with lifestyle change and medicines now have an option to get the diabetes control with surgery. Some of them may still need medicines, but that is not the target. Target is if their HbA1c is 11, now it will come down under 7, with or without medicine. And as I'm showing you 36% patients even after 10 years will not need medicine. And initially a very large number, I'll show you the results. These are our publications. So we've had first publication at 3 years. How many of our patients of diabetes were maintaining HbA1c below 6.5? Now, this 80% is the group who underwent what is called as a sleeve gastrectomy. Their HbA1c was 6.5 at 3 years after surgery. And there are 92% of gastric bypass patients who had diabetes were maintaining HbA1c at 6.5 even after 3 years of surgery. And then we followed up these patients and we found that at 7 years, 68% patients are maintaining HbA1c below 6.5 after a sleeve gastrectomy. So the glycemic control is very good. It's sustained long term, and I'll show you. So even at, let's say, with a gastric bypass, even at 10 years, about 80% patients will remain controlled diabetic, and this is the reason why this surgery should be seriously considered by all members of medical fraternity to offer it to their patients. I am almost summarizing. I wanted to make a brief presentation and do more question answers. We started this surgery. So the guidelines changed on 1st of December 2022. And we performed our first operation under the new guidelines on 16 December 22. And we have analyzed the results of these patients who operated in 1 year for diabetes. 43 of them. The minimum 3-month follow-up was 34 in 34 patients. Now look at this. 15 of these 34 patients were on insulin. And after, when we analyzed these results in January this year, only one of them required insulin, 14 went off insulin. So that is the kind of rapid change that happens in diabetes management in these patients. Now, as this is a continuous process, we have patients who have completed 1 year after their surgery. So there are 8 patients, 7 of them we have found out the results. 9.5 preoperative BMI, HbA1c was 9.5, and at 1 year after surgery, it's still 6.6. Okay. Those who completed 6 months, they were 14. HbA1c was 8.87 before surgery. At 6 months, it's 6.74. And those who completed 3 months, their HbA1c before surgery was 9.2, and at 3 months, it's 6.5. In simple terms, what I'm trying to tell, that within 3 months of the surgery, the HbA1c has dropped down by 3%. Okay, which is unheard of. I mean, most of the pharmaceutical products show HbA1c reduction by 1. We are talking of significant HbA1c reduction, and this is maintained even after 1 year. It's almost the same kind of HbA1c that you see at 1 year. And this is in these patients. What I showed you just now were patients who were followed for 3 years, 7 years, and 10 years. So these results are early and sustained in most of the patients. Now, out of these, the low BMI patients were less. I mean, absolutely low BMI patients who were just about 10 kg overweight. Those who completed 1 year, their pre-op HbA1c was 8.7 preoperatively, and at 1 year is 6.86. Those who completed 6 months, HbA1c was 8.9 before surgery, and at 1 year, at 6 months, it is 6.1. This is a mistake here. At 6 months, post-op, it is 6.1. And those who completed 3 months, preoperative HbA1c was 10.9, and at 3 months, it's 7.1. So glycemic control is achieved in most of the patients, and they maintain it. And once glycemic control is achieved, the microvascular and macrovascular complications reduce by almost 75 to 90%. And the surgical impact on cardiovascular risk reduction is by almost 50%. That means they have 50% less cardiovascular events after surgery. I'm not showing long-term results because that will require 10 and 20-year follow-up studies, which are there from other centers, but not our center. So that's why I'm not showing them. And they require a sustained follow-up. So friends, this is what happens. Now, there is a lot of concern among medical fraternity that you are operating on a person who is just about 10 kg overweight. You're doing a surgery which is similar to bariatric surgery. Will they become malnourished? What will be the complications? How much weight you will lose? Now, this is another study which was published in our Journal of Bariatric Surgery, where they have analyzed, this is the meta-analysis, 21 studies of patients who had surgery for diabetes if their BMI was less than 30. So all these 800 patients in these 21 studies were overweight patients. They were not even obese, but they were offered surgery for diabetes. They found HbA1c reduction was 2.4%, but the most important thing is they said that there is no marked weight loss. Only about 4 BMI point reduction. So if we are operating on a 28 BMI patient, he will come down to 24 BMI. If we operate a 30 BMI patient, is likely to come down to 26 BMI. As you are well aware, in India, normal BMI is 23. So it's unlikely that any patient will become malnourished or underweight. And that's the message that you should have. And as I mentioned, when this happens, when glycemic control is so good, the macrovascular complications like cardiovascular and cerebrovascular reduced by almost 75 to 84%. And microvascular complications reduced by almost 90%. So think about it. It is not necessary that anything new is bad, but it has a lot of promises for patients who are suffering from disease, who cannot travel at night because they have to carry insulin, they have to carry their glucometer, they have to, before a meal, inject themselves on a roadside stall. Those people who attend conferences and meetings, important meetings, and they have a lunch break and they have to again go and inject themselves. So there are multiple issues. Patients whose family have serious disease, like whose parents were lost because they had cardiovascular episode after diabetes, or who have a renal failure after diabetes. So for such families, this is a possible and a good option. Let the patient explore, let the patient come and talk to a surgeon like us and who is doing diabetes surgery in normal weight or overweight patients, and let them benefit from this. And because of these reduced complications, the mortality and life expectancy increases substantially. A patient who is diabetic is likely to live longer by about 9 years after a diabetes surgery. As I was mentioning, 56% reduction in mortality due to coronary artery disease and 40% reduction in all-cause mortality. It is also seen that if the patient is careful, that means he checks his blood sugar or HbA1c at least once a year, eats low glycemic food and exercises, and avoids agents which includes blood sugar like corticosteroids or psychiatric medicine, then the diabetes is unlikely to recur. Now, American Diabetes Association, in its standard of care published in 2021, said that based on various randomized controlled trial evidence, metabolic surgery achieves superior glycemic control and reduction of cardiovascular risk factors in patients with type 2 diabetes and obesity than compared with various lifestyle and medical intervention. So this is the largest body of diabetologists, or most credible body of diabetologists, who have put an endorsement and said that surgery can be done in 27.5 BMI patients of Asian origin. So this was done in 2021 and 2022, the surgical guidelines changed. And not only international guidelines change, even the national guidelines change. This is the British guideline, the NICE guidelines, which says that if anybody is more than 27.5 BMI, he can, and is of Asian origin, the surgery can be offered for uncontrolled diabetes. Same way, Indian guidelines also changed and was published in 2021, saying that surgery can be a treatment option if the BMI is more than 27.5 and diabetes is not well controlled with normal treatment modalities. It's important, friends, to realize that diabetes is a raging epidemic. We just came out of an epidemic of gigantic proportion, but diabetes is even bigger. Look at this, that in urban India, the diabetes is so rampant, all these red areas. And even pre-diabetes is rampant, but pre-diabetes is equally rampant in rural areas. 47.7%, almost 50% of the population in India is either diabetic or pre-diabetic. And it's responsibility of all of us to know these options, to offer these options to patients, and then let them decide, because diabetes is not a single disease. As you know, various types of diabetes. They are the complication rate varies between families and between patients. So let them decide what could be good for them, and surgery is certainly a good option. Despite all lifestyle changes, knowledge, diabetes education, and all kinds of medicines, ICMR very recently published that almost 77% patients have HbA1c more than 7 in India. So they remain uncontrolled diabetic even with best of the medicines. And because of this, there are various comorbidities. So number of patients who have 3 comorbidity is about 16.6%. Another 13.5% have 4 or more comorbidities of diabetes, which means almost 30% of the patients in India have 3 or more comorbidities. And if you add 2 or more comorbidities, it becomes 55%. So it's important and it's very significant that we act early, we avoid these complications of diabetes through whatever way you can do. If you can control with medicine, excellent. If it doesn't happen, think of surgery. I'll briefly play a video of another gentleman. He works for Maharashtra Police in Mumbai, and he is speaking in Marathi, but I think it's understood what he's saying.
नमस्कार, मी शिवराज बेंद्रे. मी पोलीस सब इन्स्पेक्टर आहे आणि माझी एप्रिल महिन्यामध्ये बॅरिएट्रिक सर्जरी झालेली आहे. मला डायबिटीसचा त्रास होता. माझं वजन काही जास्त नव्हतं, वजन 78 kg होतं, पण मला डायबिटीसचा त्रास असल्यामुळे मी बॅरिएट्रिक सर्जरी डॉक्टर रमन गोयल आणि मधु मॅडम यांच्या सल्ल्यानुसार केली होती. तर बॅरिएट्रिक सर्जरी नंतर माझं पूर्वी जे काही ब्लड शुगर HbA1c जो आहे माझा 10% होता, तो आता जवळजवळ 2-2.5 महिन्यानंतर 6 पॉईंट आलेला आहे. आणि ब्लड शुगर मध्ये बरीच तफावत झालेली आहे. ब्लड शुगर एकदम नॉर्मल झालेले आहेत. सर्व रुटीन चांगलं झालेलं आहे. बॅरिएट्रिक सर्जरीमुळे माझं वेट लॉस पण 14 kg वेट लॉस झालेलं आहे, पण आता माझी तब्येत स्टेबल आहे. तर जनरली बॅरिएट्रिक सर्जरीमुळे मला ब्लड शुगर मध्ये ज्या कारणासाठी मी केलं होतं त्या कारणाचा मला भरपूर फायदा झालेला आहे. आणि आता मी खूप चांगला असं अनुभव घेतो की माझी तब्येत चांगली झाल्याचा मी अनुभव घेतोय. ओकाड हॉस्पिटलचे डॉक्टर रमन गोयल सर यांनी मला ज्या काही म्हणजे त्यांनी सूचना दिल्या त्याचं आम्ही पालन केलेलं आहे आणि सरांनी आणि त्यांच्या टीमनी आमच्यासाठी खूप चांगलं काम केलं आणि मी आता एक चांगलं लाईफ जगत आहे. थँक्यू.
So what he's saying is that he was just 78 kgs and he got this surgery done for diabetes. And his HbA1c was 10 before surgery. And within 2.5 months, it came down to 6. And he lost about 14 kgs in the first 3 months, and then he stopped losing weight. So that is the kind of result that we have been seeing. And patients have been looking forward to this kind of treatment so that they can lead a healthy life. So thank you so much. Thank you, Dr. Shithil and Doc Plexus once again for inviting me. I'll be happy to answer any questions that you have, or if viewers want to ask, or they can reach out to us through you. Thank you so much.
Thank you so much, Dr. Raman, for that wonderful presentation. It was absolute wonderful listening to you. We have a few questions from the audience. With your permission, let's go on to the first question. My first question to you is, what are the long-term effects of metabolic surgery on insulin sensitivity and pancreatic beta cell function in non-obese diabetes patient?
So, this differentiation of obese and non-obese has to gradually go. Because diabetes doesn't happen because somebody is obese. Diabetes even happens in thin patients. Obviously, the diabetes worsens in obese patients because of various reasons. So first thing is we should stop talking about obese, non-obese, BMI, because diabetes has no criteria on BMI. The only criteria is insulin resistance and pancreatic insufficiency in long run. Now, what will happen in long term after these surgeries what will happen to insulin sensitivity and beta cell function? Now, as far as beta cell function is concerned, it has been seen in some indirect evidence because, we cannot do pancreatic biopsies of patients. Through indirect evidence, it has been seen that beta cells actually start proliferating. It increases number of beta cells in pancreas, which is exactly opposite to what happens in diabetes, where beta cell number continues to go down. All right. Now, as far as insulin resistance is concerned, insulin resistance remained low long term. Some of these patients who have been diabetic for a long time may still need some medicines like tablets, oral hypoglycemics. But that is a different thing because if diabetes has been there for a long time, let's say more than 10 years or more than 20 years, they may still need medicines. But definitely I believe, and there is evidence to say that insulin resistance remain under control after surgery.
Thank you for answering that. Moving on to the next question. So my next question to you is, what role does preoperative and postoperative care play in the success of metabolic surgery for non-obese diabetic patients?
What factors is it?
Yes.
Okay.
What factors plays a role in the success of metabolic surgery?
So, the success is measured by us if the HbA1c come under 7. Right? Now, what factors work if they come early? So, if somebody comes within first 5 years of diagnosis of diabetes, probably they will not need medicines for diabetes again. Right? If somebody is coming after 25 years, they will probably still need medicines for diabetes. But the benefit in terms of diabetes is the same. Even the person who is coming in first 5 years will have HbA1c below 7. The person who is coming after 25 years, HbA1c will be below 7. The only difference is that those who are coming late may still need medicines, but those who are coming early may not need medicine. But as I explained in the beginning, surgery is not to stop the medicine. Surgery is to give a better controlled disease and to avoid complications of diabetes.
Thank you for answering that. Moving on to the next question. My next question to you is, what are the key factors that contribute to the recurrence of diabetes after metabolic surgery, and how these can be mitigated?
Okay, that's a challenging question because nobody really knows the answer. But what happens, I'll tell you. If somebody's sugars are normal for 6 months or 2 years or 3 years after surgery, they primarily tend to forget that they had diabetes. If you're not taking medicines, if you're not taking insulin, after 3-5 years, you start believing that you don't have diabetes, which is actually wrong. And if they start eating high glycemic food, which should not be eaten in diabetes, if they are not checking their blood sugars, that is where the challenge is. That is why we very closely follow these patients and tell everyone that you should do your HbA1c at least once a year, preferably every 3 months. And they should avoid high glycemic food. If the sugars are better controlled before surgery, the results are even better. Right? closer follow-up after surgery with the team is absolutely essential, so that they remain aware that they have undergone treatment for a disease which is a lifelong disease, and surgery has given them control. But if they start eating, let's say, sweets or refined flour or other low glycemic food like sweet fruits, their sugars can start going up, not immediately, but maybe in next 6 months or in 1 year later. So one need to be aware that we are treating a lifestyle disease. That also used to happen, Shetil, with obesity. If somebody undergoes a bariatric surgery and starts eating unhealthy, those 15-20% patients may gain weight. But 80% patients or 85% patients are aware that they were obese, and they take care, make right food choices, and they don't gain weight. So I think making food choices, staying with a healthy lifestyle is essential, even after surgery. Then the question is, why should surgery be done? Because even with very good lifestyle and taking medicines and taking insulin, a large number of patients, like I mentioned, 77% patients in India remain uncontrolled. So I think those who can understand what we are talking about in terms of diabetes surgery, and those who are ready to follow the lifestyle, it's a wonderful option.
Thank you so much, Dr. Goel, for the wonderful presentation, and thank you for answering the questions with all the information that you have. This brings us to the end of this insightful exploration into the world of bariatric surgery with Dr. Raman. Thank you, Dr. Goel, for sharing your invaluable insights and expertise with us today. Your comprehensive presentation on the outcomes of surgery in non-obese diabetes patients has been incredibly enlightening. I would also like to extend my gratitude to all of you, our attendees, for your participation and engagement. Your questions and interactions have made this webinar a valuable experience for everyone involved. Thank you once again, and we look forward to seeing you at future events. Thank you, everyone.
Thank you so much. Thanks, sir. Bye-bye.